Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center reporting for the week of December 6, 2021. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to keep yourself, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please put your comments and questions in the comment section, send us a direct message, or email us at admin@rootsclinic.org. COVID cases, both across the world as well as in the United States, are continuing to increase, and this is very variable from state to state, but on average, cases are increasing. In addition, unfortunately, hospitals and deaths are also upticking. And as we know, these two indicators lag behind cases. So we're seeing cases go up, then hospitalizations, and then deaths. And this is unfortunately what we are seeing on average nationwide. Here in Alameda County, fortunately, we stay in this plateau. I say fortunately because at least we are not upticking. But we're plateaued both in terms of cases as well as hospitalizations. And we never quite came down as low as we did after last year's summer surge. And we haven't started upticking yet, but I think we would all be a lot more comfortable if cases were continuing to come down more quickly. But nonetheless, I think we can feel fairly confident that we are in a good place compared to many other places across the country. And this is, of course, in large part due to the fact that we have high vaccination rates here in Alameda County. We are at 76.3% of the eligible population 12 and up being fully vaccinated. We don't quite have that 5 to 11-year-old group added in on the dashboard and into those overall percentages yet. With 76.3% fully vaccinated of the 12 and up, and Oakland is not far behind at 74%. We are doing fairly well, but we still know that there are disparities in vaccination rate with our African American and Latino populations at only 61% fully vaccinated. So that's a full 15 percentage point difference between African American as well as Latino compared to the average. And of course, some groups are much more fully vaccinated. And so this is why we continue to see disparities in terms of new cases as well as deaths, and those disparities have widened since the vaccine has come out, and that is because of this disparity in vaccination rate. Now, nationwide, we have seen that in the 5 to 11 age group, we've already administered 4.87 million first doses, and 1.47 million of those children 5 to 11 are fully vaccinated. There has not been any safety signal that has been brought to our attention to this time, and we know that there's been a lot of focus in looking at that. And so we will just be waiting to hear any additional, more nuanced information about the vaccines. But at this time, it is very reassuring that we're getting close to 5 million first doses given and close to 1.5 million 5 to 11-year-olds fully vaccinated. And there's been no safety signal that's been surfaced. On to news in therapeutics. Molnupiravir was evaluated by the FDA's VRBPAC committee last week, and they voted. It's kind of a narrow outcome, 13 to 10, in favor of approving this medication. Remember, this is a drug manufactured by Merck. They submitted their request for emergency use authorization back in October. And this is for adults with mild to moderate COVID-19 who are at risk for severe disease or hospitalization. And while the initial studies looked fairly promising, a further review of the data showed that there is a 30% reduction in hospitalization and death. So not as significant as we would have hoped. But the good part about it is that it's a pill, so that's going to be much easier for people to take compared to the only other outpatient treatment that we have now, which is a IV infusion. Some of the challenges with this medication are that it is contraindicated in pregnancy. And so this leaves out our pregnant moms. We are not sure about the effects. We're concerned about the effects on a fetus. So if you are trying to get pregnant or if you are pregnant, then you would not be eligible for this medication. And I think that there's still some unknowns about how this medication behaves in the body and whether this is something that really is an emergency that should be authorized at this time. And so at this point, myself, if I have a loved one, a patient, anyone who I'm making recommendation for who has COVID-19, I am going to be recommending the monoclonal antibody treatment for now because, as you'll recall, the monoclonal antibody treatment, even though it is an infusion, it could take an hour and then maybe another hour of observation. So, a couple hours out of your life at an infusion center to get this treatment, but it really is a potential game changer. It is reducing hospitalization and death by 70 to 80%. It's very impressive. It kind of stops it in its tracks. The other benefit over the pill is that you can take it within the first 10 days after contracting COVID 19. It's always better, the sooner the better. So, as soon as you get symptoms or think you're exposed, get tested and inquire about monoclonal antibody treatment. The pill must be taken within 5 days, cannot be used in children, cannot be used in pregnancy, and the reduction in hospitalization and death is only 30% compared to 70%. So for me, there really is not a situation in which I would be recommending these pills at this time. I will be waiting for the next rounds of therapeutics that are kind of in the pipeline that do look promising, but for me, this isn't it. And I'll say that with the 13 to 10 vote, obviously 10 of the members of the VRBPAC committee did not feel that it was appropriate to approve. And there was also discussion that if another better pill is approved, that they would consider then withdrawing the emergency use. So, unfortunately, not fantastic news on the horizon as it relates to therapeutics. The other not so great news is that with the Omicron variant, we're going to have to now watch and see how these monoclonal antibody treatments are going to do. Because remember, these are specifically targeted towards the spike protein, and they kind of give you the antibodies that we are worried that you don't have enough of. Either you've not been vaccinated or you got COVID anyway and have symptoms, so we're concerned that you don't have enough antibodies or don't have any antibodies, so the monoclonal antibodies just giving them to you, and we have to give them to you at the right time, and they have to be targeted to the right COVID. So now that we've got Omicron, there's a bunch of testing underway. Some of the monoclonals are not going to be as effective. The others look like they're doing fairly well. So far, so good, because really the majority of what we're dealing with right now is still Delta. And so at this point in time, I think still the news is that outpatient treatment, catch COVID, don't wait until you're sick enough to go to the hospital, get monoclonal antibody treatment. So, whether you are vaccinated or not, if you get symptoms of COVID 19, but especially if you're unvaccinated, it is really imperative to get tested right away and inquire about this treatment. And so it's important to know where is your nearest testing site. Roots continues to provide community testing both in Oakland and San Jose, and there are a number of community testing sites that you can find on the public health department's website. And also, as I've discussed several times here, we have the rapid tests, which are a good indicator. If they are positive, you can believe it. If they're negative, you still may need to repeat. And I've gone over this in a lot of detail in prior briefings. But the update I wanted to provide today is that the White House announced a plan for free rapid tests. However, the unfortunate part of this decision is that it is in the form of reimbursement from your insurance company. So if you happen to have private insurance, then you can go on and purchase what really are fairly costly tests. They're still around $20 to $28 for a 2-pack of these tests, and you would purchase them and then you would look to get reimbursed by your insurance company. So that's some legwork that you have to do. It's not super convenient. It's really unclear how this is going to really, if this is really going to be helpful, and if it is, how it is, what's going to do to the price, and so on. I personally was really hoping that this would be a free thing for everybody. Many countries are providing them for 50 cents or a dollar or for free or even mailing them to your home. That's what I would have liked to see, is that along with those stimulus checks, we could have gotten some rapid tests and some N95s for everyone. I think that would have sent a message about how to arm ourselves with the proper tools in this fight against COVID. But instead, we are dealing with having to pay too much for these tests. And I'm very concerned about folks with Medi-Cal who are not going to be able to do this reimbursement program. Haven't heard anything about how it's going to work for people on Medi-Cal. Also for folks who are uninsured. And so I'm sure that there are provisions for these to be distributed at clinics. You can reach out to us, admin@rootsclinic.org, and we can arrange for you to pick up rapid tests for you to have at home. But essentially, for community members who are uninsured or underinsured, we will be working to fill the gap in the community to try to both provide this resource but also educate on the best way to use it. It feels like we are lagging behind as a nation in terms of using what really is a public health tool to help us keep from spreading. It is also an individual tool, and so of course insurance companies should also pay for it, but this should be something that's readily available and that people don't have to upfront pay for. And so we're hoping to have better news on this in the future. But for now, at least, if you have private insurance, you can purchase them and ask for reimbursement. And if you don't, then please know where your nearest testing site is. Inquire with them about if they have any tests for you to take home to use, and make sure that you understand the best way to use them. Anytime you get symptoms, go ahead and use it. If it's positive, believe it. If you are going to be doing any kind of indoor gathering, take the test right before the gathering. If it is positive, believe it. If it's negative, you may need to confirm with a testing site, or you may need to repeat it. And again, I went over this in great detail in the October 19th People's Health Briefing if you want some more tips on how to best use the antigen test and when to use it versus the PCR test. The other update I want to share today is regarding what we've been calling long COVID. It's now got a new name, post-acute sequelae of COVID-19, or PASC. So long COVID is sort of what we've just been referring to as people still just having symptoms of COVID long after the acute infection resolves. And post-acute sequelae of COVID-19, or PASC, includes this long COVID, but it really refers to all of the things that could be happening after the acute phase of COVID-19. And that is something that we are still learning about. And so there was a recent study published this month in Frontiers in Medicine, and it was specifically looking at the risk of death within the 12 months after recovering from COVID-19. It was looking at electronic health records of one health system and only at adult records of 13,638 patients. And they had a COVID-19 positive group that was confirmed by PCR and a COVID-19 negative group for comparison purpose, and all of these were PCR confirmed. And they were followed for 12 months after COVID-19, and everything was adjusted for age and gender and race and also conditions, comorbid conditions. And they also looked separately at under 65 and over 65. And basically, bottom line is that they found that patients with severe COVID-19, and that was defined as those who were hospitalized within the first 30 days of the date of their positive test. So those with severe COVID-19 were almost at a 2.5 times higher risk of dying in the 12 months after infection. And the causes of death were really all over the map, and it was not just respiratory and cardiac. And I think this speaks to what we've been talking about all along, which is that this virus is very unpredictable. It causes this inflammatory state that can affect all of our systems, any of our systems. It can cause neurologic issues. It can affect almost every organ in the body. And so, this 2.5 times higher risk of dying in the 12 months after infection is, of course, very, very concerning. And I think it should just be a word to the wise about that it's not just about dying of COVID, it can be about living with COVID. We know that just because 2.5 times higher risk of dying also means that there's others who didn't die who are dealing with chronic issues now. And we are already seeing that, and we don't even know really the magnitude of all of that at this time. So, certainly with more severe COVID, it is much more concerning than milder COVID. But we have seen post COVID symptoms with mild bouts of COVID as well, including the multi inflammatory system failure condition that can happen in children. So, still a lot we don't know, but more and more that we're learning, and with more time, we will continue to learn more. And now on to COVID variants. So you will recall that on November 26th, the World Health Organization designated the variant B.1.1.529 a variant of concern, and it is called Omicron. And there is concern that it is spreading faster than Delta, but there's really not a whole lot that we can definitively say still about Omicron, so we are still gathering information. We are hearing a lot of anecdote, a lot of smaller studies. Some are really downplaying it, saying it sounds like it's milder. Some are really, really concerned about the rate of spread, and I think that there are small and local reasons that seem to support those two positions and everything in between. But the truth is that we don't have enough data to know. All that we know is that some of the mutations there on the spike protein are concerning. We have now identified that it is in at least 41 countries, 600, about 670 cases. This is a tiny, tiny, tiny drop in the bucket. It's really too small to draw any conclusions. We still don't know just how contagious it is, because we are looking at these pockets of infections in different parts of the world that have very different scenarios. I think we're going to have to really understand how it behaves in a highly vaccinated population, and then how it behaves in a population that has had a high degree of infection acquired immunity. And we're going to have to see how it behaves in the unvaccinated. And we're going to have to see how it does in younger people and in elders. And there are little pieces of information that are concerning, such as younger people being hospitalized, for example, in South Africa. But once again, not enough to draw any major conclusions. So, what we're waiting to hear about more is if it is more contagious as it does appear to be, then why is that? Is it because there's something just about it that's more transmissible, or is it because of immune escape? And if it's because of immune escape, is that to people who've been vaccinated? Is that in people who have infection acquired immunity, or both? It's probably either both or neither, because the infection acquired immunity and vaccine acquired immunity do look very similar. They're not identical, and there's still a lot we don't know, even about that, even against Delta or anything else. So, still a lot of questions. We also don't know if it's more virulent or not. That is going to take time to find out, but we will find out. We'll find out likely in the next week or two, maybe three, and I think we'll just keep on getting additional information. But I do think that there's really no reason to be panicking about this. And the reason being is because first of all of the non-pharmacological interventions that we've been using, like masking and improving ventilation and not gathering in crowded indoor spaces, those things still work to reduce transmission, and those are things that we should continue doing. So we should not stop doing those things. Also, although we do not know how well exactly the vaccines will protect against the variant, we expect it to be protective. We don't know how protective, we don't know how much of a reduction we'll get, but we know that it is still the best protection that you can get, and it is the best tool in our armamentarium. Also, the pharmaceutical companies are working on a potential new vaccine. If we need one, hopefully we will not need one, but we will know more in the weeks to come. And last week I went over Omicron in a lot of detail if you want more detail about it. Our PCR tests still detect Omicron. We've also been doing increasingly more sequencing, and we want to continue to see even more and more of that so we don't need to be blindsided by variants in the future. And I'm glad that I don't feel blindsided this time. I feel like we got a lot of lead time and warning. I'm not thrilled about all of the responses, including the what I would consider unjust travel restrictions that are not necessarily based in best practices, but more of a knee-jerk reaction that looks like we're starting to dial back. And hopefully what we're doing instead is putting in place actual mitigation strategies and ways to make sure that people who are infected with Omicron, Delta, or any other COVID don't actually get on a plane and import the COVID anywhere. And also that when they land, when travelers arrive, that we have the appropriate measures in place to test and to quarantine as needed. And so hopefully we will be able to build up those strategies. And in the meantime, I think what's important to note is that we have our hands full with Delta. So it really, we can keep an eye on Omicron. We definitely should be preparing ourselves. But the fact of the matter is that we are really in a upslope of cases all across the country. We're doing rather well right here in the Bay Area so far, but we've seen it before and we will likely see it again, that we lag behind other parts of the country and the world. We've been having wonderful weather here in the Bay Area, but it is going to start getting colder soon. And I think we all anticipate a wintertime surge, and we're just going to be doing everything that we can to flatten that curve and flatten the death curve, really, because cases are no longer really the indicator that I think we need to be focusing on. We need to be focusing on preventing hospitalization, severe illness, and death. So to flatten the death curve means really that people will need to be vaccinated, because people who are dying are really people who are unvaccinated. We also do have the group of people who are vulnerable, who may have not mounted a good immune response to the vaccine, or people who are elder who may have had a waning of immunity, and that is where the boosters come in. We've talked about that many, many times, but basically anyone 18 and up who would like a booster and is 6 months out from their mRNA or 2 months out from their J&J can get a booster. But especially, we're mostly concerned about those people who are at risk of doing poorly if they catch COVID, and those who are at risk of spreading it to someone who will do poorly. So if you have someone who's immune compromised in your bubble, then you may want to consider getting a booster, even if you are not quite as concerned about yourself doing poorly with COVID. And so this is where all of our individualized and tailored decision making comes into play. And I will just put in my usual or frequent plug for a primary care physician. We all deserve one. We should all have our own physician. So if you don't have one, please get one, because they should be able to talk through all of these things with you. And if you don't have a primary care physician who can talk through these things with you, then find one that can. And so we all deserve to have that relationship and to have our very own expert in our corner, which is our own primary care physician. So if you don't have one, please get one. And I will just say one more thing about the non-pharmacological intervention, which is the mask. This is really important. And I think that if you have not stepped up your mask situation, I think now is definitely the time to do it. We just don't know about this variant being more transmissible, but we do know that Delta is already transmissible enough. And if you are going to be indoors, particularly for any length of time, it is really important that you have a high quality, high filtration mask. And so now is really the time to start thinking about the N95s or the KN95s that are comfortable enough for you to wear for a period of time. Because if you are going to be in an indoor space for any period of time, then all those cloth masks, surgical masks, they gape on the sides, they don't provide filtration, and they're really just kind of a barrier against droplet transmission. So yes, if someone's near you and they're spraying on you, you want to have some covering, and most coverings will do. But that's not what we're mostly worried about. We're mostly worried about aerosol, which means that you need to have a mask with a good seal and that can actually filter out those teeny tiny particles that are COVID-19. So I have been asked about where to find masks, and I will tell you that there's a lot of information out there. It's actually kind of a little overwhelming sometimes. But one of my favorite places to go to see where vetted masks are is called Project N95. I put the link in the post. And Project N95 actually will vets the masks, and you can purchase them there as well, or you can just find out the make and everything and buy them from a legit retailer. Unfortunately, there are a lot of KN95s in particular that are fraudulent, so you do have to watch out for that. The other source, if you really want to get detail with it, is a gentleman who calls himself the Mask Nerd, and he's pretty much a mask nerd. He does some very, very detailed analyses of masks. He's got spreadsheets, he's got videos. I put the link to his YouTube channel in the post, and he really goes into detail. So if you really want to go there, he has a video about the best masks for children, for people with small faces. He does all kinds of very interesting studies that actually show you just how ineffective some of these other masks that folks are wearing are. And so I think now is the time to really invest in some high quality, high filtration masks, especially if you will be doing any gathering indoors. Remember, in general, the safer choices are that outdoors is definitely safer than indoors. Farther away is safer than closer together. And this is particularly when you're outdoors. When you're indoors, then a shorter time is safer than a longer time. But if you're going to plan to be indoors for a longer time, then I would recommend checking out those rapid tests for everyone to do before they come in. Make sure that you have a guest list so that you can contact everybody in the event that someone does get symptoms or test positive, and get a high quality, high filtration mask. And remember, if you get symptoms, get tested right away. And remember, those symptoms could be a headache, they could be a sore throat, could be sneezing, could be loss of taste and smell, as we know, but it could also be nausea, diarrhea, really pretty much any new symptom. Go ahead and err on the side of caution and get tested. And if you test positive, then please inquire about monoclonal antibody treatment. If you think you're exposed, get tested in 3 to 5 days. And everybody, please consider taking a multivitamin supplement, additional vitamin D supplementation, manage your stress, get some exercise, eat a well balanced diet, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you for joining us. Hope to see you next week, Tuesday at 10 a.m.